Hi guys, can one of you tell me if you can hear me?
Yes, sir, you're audible.
Is that Vijay Lakshmi?
Yes, sir. Hi, sir.
Okay.
Good evening.
Okay. Nice to meet you. Thank you very much. I'm very grateful. Vijay Lakshmi, can you just let me know if you can see the presentation?
Yes, sir, it's visible.
Okay. Thank you. Folks, a humble request. Can I ask you to all mute yourselves for the initial bit of the session?
Hello and good evening, everyone.
Good evening.
Oh,
Well, welcome everybody. So we're gonna make a start as it's exactly 7 o'clock, and I was just gonna say that I am very punctual and sharp for time. Just to give you a little bit of background and some ground rules about the sessions going forward. Obviously, because these are recorded sessions, what is very important is that on entry, everybody is mute. There will be periods where we'll be asking questions or where you'd like to ask a question. So there'll be regular pauses during the talks so that we can actually give and have that interaction. But just it's really important that we limit the background noise just because the participants who won't be able to attend, who will then be watching this later on. Just a few other very important ground rules. First of all, having a high-speed internet connection is really helpful, especially if you plan to share images, anonymized images for peer review in loops. I think the other thing that I would strongly emphasize is all the talks will be available through a private channel, just because we will be peer reviewing images, even with anonymization. My humble request is that only the participants should access these videos when they're on the private channel. They'll be accessible to you, but obviously you can share them. So those are just a few of the ground rules to start off with. Now, can I just ask whether everybody can see my screen visible and I'm audible? I should have asked that at the start. Any one person?
yes.
Yes.
Excellent. Okay. So is the screen now full screen and you can see the presentation?
Yes.
Excellent. Okay. Thank you so much. So what we're going to do is we're going to go through 3 modules today. And from our perspective, what we will be doing is basically setting up an introduction to how you're going to basically have and take your journey through the process of learning lung ultrasound with me. I'd like to emphasize it's a two-way learning process. We will learn from each other. I'll be learning from you. And I am going to kind of say that I've been doing lung ultrasound since 2016, but I'm still in the learning phase. Pretty much what I would say, probably L4, which is something that I'll explain to you. But what is very important from our perspective is that we're able to interact well during this journey. After the introductory slide, what we would be doing is taking you through a little bit of how you're going to use the portal, and then basically take you through what competencies and how we plan to kind of let you move forwards with competency acquisition. I think we must acknowledge everybody comes from quite a varying background at this particular point, and some people will already have point of care ultrasound skills. There'll be people who know how to head scan, do echocardiography. But I think we must also respect that there are people who might come into the course who have virtually no ultrasound experience. And I think the aim from our perspective is to basically take you from a kind of a novice level to a level where you feel relatively comfortable being able to take your progress forwards with learning lung ultrasound. Again, the challenges for us will be how we pitch it and how, from our perspective, we take things forward in terms of your learning. So bear with us. There are imperfections along the way. We're very open to feedback, and you're the first batch in the inception batch. So, your feedback will be very valuable. So first of all, welcome to the course. A little bit about the MPROvE Academy, who I am. So I am a consultant neonatologist. I currently work at the Cornish Hospital. I have trained in 3 different countries. I have the benefit of having worked with a lot of very experienced colleagues, 5 of whom who will actually be on this course, and 1 of whom has actually trained me. So I think, benefits of being able to learn from my peers is something that I will share with you. You will be my peers, and you will obviously be training me as well. And that is through sharing images, sharing your knowledge. And I think that is a very important aspect of the course. So the MPROvE Academy is not for profit. That's a very important statement that we make. So of the course, we have 40 participants. 12 of you are scholarship places. The remaining participants consist of people from high and low middle income countries. I think it's very important that we realize that the accessibility of training and education can be quite a challenge. So again, what I'd like to emphasize is that we don't intend from our perspective to greet you with the heaven and earth in what we're going to be able to provide. But I think what is very important is that we will be providing you with a curriculum evidence-based approach to learning ultrasound. We currently run 4 modules, which include the lung, the brain. We'll be running bowel, vascular access, and airway. And the lung is the first of our modules that we're running at this particular point. So I always will like to start with a case. And I think one of the journeys that has made my learning very good is the fact that clinical correlation with a case is a very important aspect of learning any kind of ultrasound methodology. And let's start with a little bit of interaction at this particular point. So I've got a baby who is approximately 90 minutes old. This is a baby, 37 weeks of gestation. This baby has been diagnosed with a left-sided congenital diaphragmatic hernia. This was a late diagnosis at 30 weeks. And you have an X-ray at this particular point. So I'm just curious. So I'm going to ask Vijayalakshmi. Vijayalakshmi, what do you think about the X-ray?
So the X-ray, it seems like if you'll go for the lungs part, the
Yep.
right side is hyper expansion is seen.
Okay.
Cardiac shadow is shifted to the right side. The left side opacities are seen, and diaphragmatic line is not that much clear. It seems as if the bowel loops are inside the left side of the chest. So.
Okay, excellent. Just going through
And
that
coming,
X-ray.
yes.
Yeah. Did you want to say anything else? Yeah.
No, ideally, stepwise we should go, but I've explained in short only, like the tubes and like the OG tube tip. Actually, I'm not able to see it properly.
Sure. So the tube is probably a little bit low. You can see a nasogastric tube that comes up into what
Yes,
looks
yes.
like bowel on
Yes.
the left side. You can see a UAC going up there. So I'm just curious, anybody else have any comments?
And the abdomen gas shadows are absent in the abdomen actually.
Okay. Thank you. Zaradin, you looking?
Yeah, it's there's a very crisp edge for the lower part of the right lung, just above the diaphragm. I'm not sure if it's an air leak or it's just a picture that has been very, very complicated by the congenital diaphragmatic hernia.
Fair point. I think I'd accept that. So I'm just curious, anybody, how many people, just in the messages, how many people think there might be a right-sided pneumothorax? Let's just write in the messages. We'll come back to that at the end. But if I just give you the history to say that at 90 minutes of age, we have a baby who's saturating about 75% in 100%, who's kind of heading towards the oscillator. So we're on decent pressures of 30/6 and 100%. We have started a trial of nitric, and we're not saturating. So anybody want to come in on what you're going to do next? Okay, let's pick somebody. Jean, I can see you there. Do you want to have a go at what you think you might want to do next?
So here it's quite a difficult case because clinically you have a baby who's not saturating and 100% oxygen, so something needs to be done. I think
okay,
here,
so we have a lot of comments at the moment
ultrasound,
where everybody's quite concerned that there is a right-sided pneumothorax. Kirti, do you want to
Yes.
give us a little bit of a feel of what you might want to do?
so I would do sorry.
So one is that we pull back the ET tube first, see, optimize that. And then because these CDH babies tend to have associated cardiac dysfunction and even cardiac anomalies, I would like to rule out if there's something like that and we're just pushing with FiO2 trying to reach saturations of 100% when there might be an associated cardiac disorder.
Okay, fair point. Jean, you were coming in.
Yes, it was just to say here, lung ultrasound would be extremely helpful in differentiating between a pneumothorax and possible severe pulmonary hypertension, where you might see oligemic lung fields.
I think that's a fair point. Anybody else?
Shweta, this is Shweta. I just wanted to say we need like a three-dimensional view to rule out this. Might be there was because of the bowel. Because we cannot evaluate in a two-dimensional view.
Okay, so a few things that you could do in this particular situation. This is kind of a baby where transillumination was very difficult. I would say clinically for us. I think, the key question is you wait and the baby deteriorates further and you're kind of sitting on a chest drain. My view would be that airway breathing usually comes before cardiac. And I would definitely, if I've got a pneumothorax, they want to sort breathing out. And my worry is the longer I delay, this gets worse if potentially there is a pneumothorax. The other problem is I haven't recruited much. I mean, there's bowel in that left chest. There's probably collapsed lung there. But I'm dealing with a normal lung that might just be very hyperinflated, reducing venous return, and again, perpetuating pulmonary hypertension. So a few things. Now, a lung ultrasound can help. And this is a lung ultrasound on the baby. So as standard terminology, which I will teach you in due course, we'll be talking about lung ultrasound in the form of standardized views. So we do a right anterior upper and a right anterior lower, which are called R1 and R2 views. And this is what the R1 view looks like at this particular point. And what you can see is there is a little bit of lung sliding, but a predominantly A profile. There are no B lines, which I will explain. But when you come to the R2 view, what is very classical is that your lung is not moving at all, and neither the pleura is moving. And all you can see is dominant A lines without a B profile, just above the liver. You can see a little bit of pulse that you can see over there. And this, if you put M mode on, and we did, basically gave us a barcode sign, which is suggestive of a right anterior pneumothorax. It's a diagnosis that we made within 60 seconds of actually putting the lung ultrasound probe. Now, clearly, when I play them together, what you can clearly see is lung moving in the upper zone. When you look at the left side, you can see lung that's completely collapsed over here. Thymus that you can see over here, with a little bit of what you see as lung pulse because the heart is beating. So you haven't got much in terms of the left lung recruited. But if you go lower down, what you can classically see is bowel in the chest where you have ribs and you have lung on top of that, which is completely collapsed. So we do have what we can confirm is a left-sided diaphragmatic hernia. Now, we'd antenatally confirm this, but there might be babies where you have to make a postnatal confirmation, and lung ultrasound can help with that. I mean, this baby, from our perspective, had a chest drain put in, recovered very quickly. And actually, when we did an echo, we didn't have much pulmonary hypertension at that particular point. So it's just interesting how lung ultrasound can be a very good, rapid modality for making a diagnosis in situations where you might want to avoid handling of a baby, another chest X-ray. It can be done very rapidly. So what do we intend to achieve with our course at this particular point? So our course will be run over 12 weeks. I think as a start, what we are going to teach you, assuming we're all starting from the same level, is getting you familiar with the basic principles of ultrasound physiology. Lung ultrasound in particular needs to have an element of, I would say, ultrasound physics discussed. And that will be a topic that we will cover next week. We will then take you through what we call as pattern recognition. And in particular, standardized terminology and nomenclature are a very important aspect of learning lung ultrasound. In that if you read the literature, even among, I'd say, the neonatal fraternity, there are numerous terminologies that are used, some of which aren't standardized and some of which actually are used and represent exactly the same thing. The problem is they can create a great deal of confusion. And I think if you're planning to implement lung ultrasound as a strategy for management in your neonatal unit, you should have a standardized protocol which addresses everything, including the terminologies that you use, so that you know you're saying the same thing when you make a diagnostic interpretation. I would also emphasize that when you identify normal and you try to differentiate that from abnormal, again, there is a learning curve between identification of standardized profiles, which varies from how the adults have described them. While Daniel Lichtenstein's classification is still valid, there are profiles in the transitioning newborn, in particular the term and the near-term neonate, which is slightly different to the classifications that have been proposed in adult literature. So it's very important that we learn to standardize that terminology, and we'll be teaching you an approach to that. After the first 4 weeks, I think the expectation is that you will be able to understand pattern recognition. You will be able to differentiate normal from abnormal based on visual learning. And then after that, the expectation would be that we would start delving into what we call as the different lung pathologies. Now, a very crucial aspect of this course is the emphasis that you learn different lung pathologies on ultrasound. But what is very important is that you have clinical correlation. I cannot emphasize that enough. So if you have a baby in air who has dominant B lines and a wet lung profile, really the management is based on what you can clinically see as opposed to just the lung ultrasound alone. So when we're using lung ultrasound for diagnosis of lung pathology, we're using it adjunctively in relation to clinical correlation, and I would say, if necessary, radiology. Radiology in, I mean, chest x-rays. Now, I suspect by the end of 8 weeks, we'll be in a situation where we would be starting to peer review images in a structured way, which we will give you. But in the last 4 weeks, we will be taking you through the different lung ultrasound protocols that are used for management and diagnosis of respiratory distress syndrome, bronchopulmonary dysplasia, diagnosis of pneumothorax. So the intention is to then put the different pathologies that you see into diagnostic algorithms that hopefully will give you a better understanding and approach to how you approach a diagnosis. But in particular, some of those protocols will also assess how you implement management strategies, in particular the use of lung ultrasound scores for the use in RDS, lung ultrasound for prognostication, diagnosis of bronchopulmonary dysplasia and chronic lung disease, and in particular, how you would clinically approach, say, a proposed strategy like LISA or INSURE in the context of RDS when you're using lung ultrasound. Now, how do we aim to take this forwards? So just to let you know, the initial plan that we had was a 5-week kind of a course. I think realistically, that's probably well beyond what we can achieve in the time frame. So the course now for all of us is 12 weeks. Now, at the end of 12 weeks, what you will have is you will have a 6 to 8 week period of consolidation for you to continue digesting content. But more importantly, during this period, the expectation is that you have done and you have completed at least the theoretical aspects of the course with a view to then sitting an online MCQ for certification. In the first 12 months, for those of you who are interested, we will be looking at peer review of your images in an anonymized way. I will explain how you will do that further on today. But more importantly, I would say that if you plan to take up the course and not practice, then I would say that you are losing out on a huge element of experiential learning, which is a critical aspect of any teaching course, that's face-to-face or online. What is the course format like? So we have a mix of content. So there's didactic content that you can read on the website, which I will take you through. There will be webinars with PowerPoint content. So the intention from our perspective is we can have a little bit more of interaction by showing you cases. Every session, every webinar from after the first 3 talks will start with what I would say is peer review from your side. And we will be dedicating about 30 to 45 minutes of peer review to have a look at your images, to critique them, obviously to kind of try and hone any skills. A lot of you might actually have skills that are absolutely excellent. You might have prior experience, but there may be those of us who need that little bit of critique. Importantly, from our perspective, we will be talking about strategies to try and improve ourselves. Now, in the embedded content, we realize that not everybody can actually attend the webinars. So all the didactic content has got embedded videos in them. Now, these videos cover the entire curriculum to the point where if you are not a visual learner, you don't like reading, and personally, I hate reading textbooks. I find them absolutely terrible. Then what you will be able to do is watch those videos, and you can actually watch all the videos and learn just as well as by reading the content. I think the advantage of reading the content is for those who want to go in for a little bit more deeper exploration. The referencing, the articles are all referenced. You can click on the links, access the web content. We will, from our perspective, be able to provide you with an article library of articles which have and are Mendeley approved for open access sharing. For other articles, you might have to go through your respective libraries, your your Open Athens accounts to try and see if you can get access to them. There are some articles which have been made available by the eminent colleagues who will be teaching you, again, with their consent, that we will be able to share with you. Now, each 4 weeks, we will have an assignment. I will be sharing that with you later on, but we'll have a little bit of, I would say, online interactivity and a little bit of homework for you. Now, coming to nuts and bolts about your account and access. So on Monday morning, all of you, my impression is, should be able to log into the MPROvE Academy website already. But in your accounts, you will see a chapter which looks like this, which will be detailed a skills-based course, neonatal lung ultrasound. That basically will have course material and chapters, as you can see over here. And at the moment, there are 10 chapters which have been completed and 10 more which will be uploaded over a period of 4 to 6 weeks. Each chapter has its embedded figures and videos to kind of reinforce your learning. This is what a kind of an embedded video looks like. So in the introductory section, you'll have the written content, but embedded videos can be clicked on directly and they can be viewed. All these videos are uploaded to kind of YouTube. References are embedded in 2 ways. So they're either referenced with a link, which you can click on, or you will have, say, for example, if they're files or kind of learning tools that we've kind of put in, there's a section for references, which is usually either on the left side of the screen or at the bottom. So this kind of is a little bit of an introduction to how we plan to take lung ultrasounds forwards. I think that brings me to the most important aspect of what we will be doing, and that is obviously providing you with a platform for experiential learning. Now, it's really important that once we've completed a video or a webinar, that you try to review it, especially I would say in the first month before the next lecture. After that, I'd say the lectures can actually be viewed in any order, and that you're kind of, with the webinars, able to go through the content and read the online content. But the most important aspects of what we're going to cover is going to be the first 3 weeks. Tomorrow, we'll be covering lung ultrasound protocols, the machine, the infant, in particular, how you want to do lung ultrasound on the unit, use your machine, how you'd be storing and anonymizing your images. Next week, we will be covering ultrasound physics and pattern recognition of A and B lines. And the week after that, we will be covering lung profiles. So it's very, very important that you see these particular talks in sequence. Now, interaction with your tutors. So what I'd say is that a lot of the webinars, especially the invited speaker talks, might not be as interactive. And the sessions where you have peer review, which I will clearly label, will be more interactive for you to share your images. Now, the reason that I'm putting this up is because you may well have lots of questions that come up after you have seen a webinar or while you're reading the web content. You might need resources, you might want a particular article, or you might feel confused about a particular aspect. And the WhatsApp group that we've created is the best way for us to raise that. It's also going to be a really good forum for, I would say, peer support, in that you'd be able to kind of ask questions which a lot of your peers would be able to answer in addition to the tutors that you have on the course. If you can't and don't want to use the WhatsApp group, then the other way to kind of contact us is through the MPROvE forum channel. This will be updated once a day. My humble request is that the WhatsApp group is much quicker, much faster, and we're using the power of about 40 other colleagues, as opposed to the forum channel where You just have me who can actually see it and yourself. So that basically brings us to the end of this particular section. I'm going to pause share. So any questions about the current module before I take you onto the website, guys? Anybody?
No, sir, no question.
Okay. That's not nice. You should have some questions.
No, I think it was just, that was very clear. Thank you.
Okay, so now I'm just going to give you a very quick overview of the website, the web portal. Can you see the web portal?
Yes.
Okay.
Yes, sir.
So for all of you who've registered, when you go to your profile, which is up in the right-hand corner, you have My Account. Now, My Account basically has your account details. It lets you change your password if you'd like to do that. Again, we've given everybody a common password. If you want, you can keep that, but you might want to change it, and that's the approach. Your course is under skills-based learning, and this is what it looks like. So this is point of care ultrasound in neonatal care. Once you enter the post portal, what you can see is chapters. Now, as you complete and read course material, the actual chapter, the course will track your progress. Now, once you've completed all modules, you can go back to the content at any particular point of time. But the expectation is by the end of 12 weeks, you would have completed at least 13 of the 20 modules, which I'll email you, which are essential. And all the questions, when you do the exam-based learning, and the exam will be based on those 13 modules in the syllabus. When you go to your initial module, this is what the course material looks like. Now, videos are added from time to time, both embedded and our own videos. And clearly, this is a summary of the videos right at the top in the left-hand corner. But again, what we covered today is very succinctly summarized in the written content. For those of you who want a 5-minute overview of what we're going to discuss over about 90 minutes, I would strongly suggest you just look at the video. Each video has been produced in a very structured way. So I've been researching this since 2012. And what is very clear is your attention span is crucial for me. So what I'd say is any content that's been produced has been produced in videos mostly of a length of 3 to 5 minutes. But the occasional video, which is probably very important from the perspective of your learning, will stretch up to 10 minutes. But the intention from our perspective is that those videos summarize all the written content in a very short period of time with a visual element. Now, this is related to Kolb's learning cycle. I just hate reading. Some of you will love it. But if you gave me a book to read, I'm sorry, it's just not my cup of tea. On the other hand, if you allow me to kind of visually reinforce my learning by watching a video, for me, it's much more powerful. If I then actually put that into practice, then that actually helps consolidate my learning and I become what is a doer. So I complete the whole of Kolb's cycle. So all of, I'd say the content is basically summarized in the videos in each chapter. Now, at the end of each chapter, you have a section on resources and lectures. So for some of you who might want to look at the PowerPoint, in addition to watching the video, you can click on the link and basically your PowerPoint will download onto your system. You can see it in real time, as you can see on the screen over here, and you can download it. Now, just to mention, the PowerPoints will be updated with content from time to time, and we'll email you if that is the case. Your program at the moment, the most up-to-date version is right at the bottom of chapter 1. Once you've completed each chapter, you can go on to the next chapter. And this is a chapter on the introductory elements. Now, these are what your references look like. And you can click on each reference. And the reference will take you right to the article, some of which are Mendeley enabled, completely open access, so you can actually see them. But again, all articles that we've used here are clearly referenced to their link. Some of them will not be free, and it will not be possible for us to be able to provide you those articles, and you might have to pursue them through your institute. Again, just an example of the resources section right at the bottom. So these are embedded videos that you can go through, all very short ones, which basically take you through what A lines, B lines look like, how to work out a lung ultrasound score. The summary section at the end basically summarizes each chapter, but by the end of the course, you will come to a point which is called examination and testing. This portal will open after 16 weeks. So the idea is that after your consolidation phase, you will be able to then take your examination and testing. Now, for those of you who would like to, we have a section, a logbook, a standardized logbook that you can keep. It's downloadable, and it's in the section on learning and training in lung ultrasound. So right at the bottom, you can have a look at that. But it's a logbook that lets you basically keep a log of all the images. Now, it basically covers the entire competency-based curriculum that we would expect you to, I would say, meet a standard of. So any questions about that? That's the website in a nutshell. Obviously, if you have any problems, use the WhatsApp group. You can send me messages. Very happy to help. Any questions, guys?
Sorry, Ali, can I ask you a question?
Yeah, please.
I'm trying to log in my account, and I logged in and I already had an account, but I can't see all this stuff that you showed us. I presume that will be from Monday, I believe, right?
That is correct. That's correct. So Monday at 12 o'clock Dubai time, all of you will be able to access the module. The module at the moment is just having some work done on it. So we're just embedding some more videos in it. So just again, everybody should be able to access the module by 12 Dubai time on Monday. If you have any problems, you can come back to me. Very, very important to say that there will be periods where the module is shut for short periods where we're updating videos. We will let you know in advance. I mean, there will be short periods, but usually done overnight. But there might be periods where you can't access the module. And it will basically appear as the module being frozen. So you'll be able to see the module, but it will be frozen. So we'll let you know when that is the case.
Yeah, great, thank you.
Any other questions?
This logbook that's mentioned, will it be an account of all the things that we do after the classes and then upload them on them so that there's a record of it on the logbook? Is that how it works?
So the logbook basically has two options. The logbook is intended to be used in three ways. I'm going to come to that if that's okay in the next talk. Is that all right, Kirti? I'll answer that question.
Yeah, definitely. Thank you.
Okay, no problems. Okay, so we're just going to close the accessory screens. So we're just going to go through lung ultrasound background very quickly. Can you see my screen?
Yes.
Yes.
Okay, so the presentation is visible?
Yes.
Yep.
Okay, excellent. So what we're going to talk about now is basically the background to lung ultrasound and why it's come up as a modality for kind of diagnostic use in neonatology. So lung ultrasound has been used for a long time in adults. And clearly, for those of you who are using it for the first time, there is this kind of sometimes thought process that what you're looking at is actually looking at lung anatomy. But the fact is what you're actually looking at is artifact that's created by the different lung structures, which then gives us patterns which we intend to recognize. The applicability of that using ultrasound probes in adults was demonstrated and taught by the father of lung ultrasound, as I'll call him, Daniel Lichtenstein. Now, he has basically developed the guidelines for recognition, the definitions for the nomenclature and the protocol, and also developed the BRU protocol, which is something that we've adopted to try and kind of streamline how we define different aspects of the normal lung and different aspects of the abnormal lung. I think for me, the benefit of lung ultrasound as a diagnostic tool is probably most importantly in the sickest, most small, extremely preterm babies. And in babies where we do not want to have a lot of handling with radiology and chest x-rays. It's something that can be done relatively rapidly. It can be done alongside cranial, cardiac, and bowel-related point-of-care ultrasound. And for an extreme preterm baby in the golden hour, I would say that being able to use point-of-care ultrasound means that you can do your head, lung, vascular access in one sweep. We call that the golden hour sweep. And it literally takes 5 minutes if you're a very experienced operator of an ultrasound machine. I think the advantages in terms of adjunctiveness to your diagnosis in situations like this is extremely crucial. I mean, I've just given you an example of a baby with a congenital diaphragmatic hernia, where we were able to actually put a chest drain in without actually doing, a lateral decubitus view to try and make a diagnosis of a pneumothorax. And I'll be showing you numerous cases where you can avoid radiology, but more importantly, where lung ultrasound might actually help you make a diagnosis of what might be a clinical radiological conundrum. Now, it's quite easy to use. It's non-invasive, so it can be performed quite quickly. We use it bedside. So, there's some babies where you have to use a lot of diagnostic tools by actually moving the babies to radiology. And a good example is, the diagnosis of some modalities like a tracheoesophageal fistula might need a contrast, but a lung ultrasound can actually be done bedside to evaluate lung disease. But more importantly, it can be done bedside in a non-invasive way to actually follow up and assess the severity of conditions like respiratory distress syndrome, conditions like, I would say, pneumothorax, but it can also be assessed to respond to look at the response to treatment. Now, a very good example is treatment of a pneumothorax where you put a chest drain in and see spontaneous resolution. But diagnostic procedures, in particular needle thoracentesis, I am telling you right now, I do not stick a needle into a chest with pleural fluid without doing a lung ultrasound. And I'm going to give you a very simple example. So we had a baby who had a chylothorax, which had been drained for an extensive period of time with multiple chest tubes. And this baby basically developed acute hypoxia with desaturation while being intubated and ventilated after a chest drain had been removed. Now, this was a few days after the chest drain had been removed, and the chest x-ray showed what was clearly a right-sided anterior pneumothorax. But what was not known is that the right lower part of the lung was quite actually adherent to the chest wall. And the drain was put in a position where it just went into lung, and that baby died. Now, what I'd say is that diagnosis of both pleural fluid and pneumothorax and diagnostic paracentesis using ultrasound, I would say, is becoming quite common. I think for pleural fluid, it should be the norm, and it helps you identify exactly where you would like to put your drain. But what is important is once you've actually done the treatment, you can actually then assess, not just clinically, but look at the severity. And a good example is I've drained a chylothorax with a butterfly needle, and actually you can see the lung expand under ultrasound to the point where you can then remove the needle, because if you leave the needle in, what will end up happening is you will puncture that lung and you will create a pneumothorax, which will be iatrogenic. So it is a very powerful tool. It does need a lot of skill, but something that can be done. I think what is very important is that it avoids ionizing radiation. Now, I'm just giving you a feel. So an extremely preterm baby, the literature shows, can actually have up to 40 x-rays during its lifetime journey with us on the neonatal unit. 40 x-rays, that's a lot of ionizing radiation. If you add to that the fact that some of these babies will have contrasts, they will end up with a lot of other investigations that add to that. The ultrasound is something that actually avoids radiation, but more importantly, it involves the handling that is associated with x-rays. There is absolutely, it's not even emerging. I'd say that there is good evidence that certain lung pathologies in neonates are better diagnosed by ultrasound as compared to chest x-ray. The sensitivities and specificities are much higher, and rapid diagnosis is allowed with this bedside tool. I've already talked about the benefits of being able to use this in the extremely preterm baby, where you minimize handling, you minimize exposure. There are, however, challenges, and I think you should know them, and we will be addressing them in the course. Now, we, unlike in adults, have babies, and babies, when they're born, they have what we call as transitioning lung. Now, there is a huge difference between transitioning lung, which could be normal, where a baby is basically going from a fluid-filled lung space to one that should be air-filled, creates a lot of diagnostic challenges. And the reason for this is a lot of adults performing scans on those babies might actually think that there are, I would say, pathologies like pulmonary edema and other pathologies that actually are just normal transition of lung. But being able to differentiate this from an acute infective process can be very challenging. And I would say a huge amount of clinical correlation is needed in situations like this. You might have to do serial scans. Now, this is quite crucial because a lung ultrasound is just like a chest X-ray. What it is telling you is the lung ultrasound appearance of that lung field at that particular point of time. Your index of suspicion and your clinical correlation are absolutely crucial. An example that I can give you is a baby who is acutely desaturating, where you think there's an pneumothorax. You transluminate and you find nothing. With a good index of suspicion, the baby continues desaturating. And one of the things your algorithms in resuscitation will teach you is you come back to airway breathing. And you make a diagnosis of a pneumothorax again by transluminating after a few minutes. I've just recently been in that situation for a baby who had Lisa, who was bradycardic and acutely desaturating. And clearly from our perspective, lung ultrasound can have a very similar kind of problem, that you might have a baby where you have a small pneumothorax or no pneumothorax who deteriorates suddenly. And when you do the scan, you don't find the findings. But more importantly, if you repeat the scan after a period of 30 minutes, you actually have positive findings which correlate with the pneumothorax. So what is very important is that you don't lose your ability to clinically correlate and to go back to its use where you think it's appropriate. Now, a lot of babies are quite chubby. Certainly from our perspective, they can have a lot of adipose tissue, and that interferes with your ability to get good images. But more importantly, there's certain conditions that you can't diagnose using lung ultrasound. And I would advise caution if you are trying to approach those conditions. So PIE, pulmonary interstitial emphysema, overinflation, these are conditions in particular that will not give you a very typical diagnosis. I will be discussing a few cases of PIE with you, and what you can see is that they can have virtually any lung ultrasound pattern. Most of these diagnoses are actually made by chest X-ray. If you have air outside the chest, clinically, that can actually hinder the movement of sound waves and completely obscure any lung ultrasound appearances. You can see here, you can't see any pattern over here. You can see a little bit of pleura over there, but there's nothing else. And you must realize if you can't see anything and it's not working for you, there is a problem. So like in DOPE, you have an equipment failure. You can have problems related to air in the chest. Most important, while lung ultrasound, in my experience, and I'm sure my other colleagues and authors will share with you that they feel is safe, there is some element of studies now which are being done, preclinical studies on animals, which show that it causes ultrasound-induced pulmonary capillary hemorrhage. Now, this is 2 studies. I've got the referencing that's part of your kind of course. You can see the reference, but what I'd say to you is that I think the emphasis with this is that you need to minimize the amount of duration for which you're actually doing lung ultrasound. The use of Doppler in particular is associated with thermal effects. Luckily in lung ultrasound, while we use Doppler, we don't use a lot of it. We use a lot of M mode. So you use Doppler to kind of look at vascular structures. But what is very important for me, and I am going to highlight this again and again and again, you must not forget your baby while you're doing ultrasound. You are, and me, when I'm doing an ultrasound, we are hugely fixated on the image on the screen and hand-eye coordination to optimize that image. And I can't emphasize enough that putting a probe on and holding it there can actually impede the baby's ability to breathe. It can impede the baby's ability to ventilate effectively on a ventilator, and it can have very profound effects. So what is very important is that when we do lung ultrasound, when we do any ultrasound, for me, it's a 2-person process. It will always involve the nurse taking her permission, but more importantly, making sure that she can actually keep an eye on the observations and the baby to make sure that I'm not doing anything that's actually compromising this baby clinically. So We've discussed a few of the pitfalls of doing lung ultrasound. So again, it's a static ultrasound image. It's like a single X-ray. So we know that lung pathology is dynamic. So be aware that sometimes in trying to make a diagnosis, you might have to follow a baby up with serial lung ultrasound. A very good example is transient tachypnea of newborn. While it has some very typical lung ultrasound findings, like the double lung point, it may take time for that appearance to kind of come into your lung ultrasound images. And it might mean that your first ultrasound basically shows a completely white lung, which kind of makes you worried about the potential for RDS. Now, what is important is look at your baby clinically. So a near-term baby delivered by cesarean who's grunting and slightly tachypneic could have transient tachypnea of newborn, but if there's GBS and PROM in the background, it could have a congenital pneumonia. And or if this is a section done at 35 weeks, this baby could well have or be amongst the 5% of babies who have RDS. Now, what is going to tell you the diagnosis is not just your lung ultrasound findings. It's the clinical progress and the clinical course that that baby takes. And what is very important is that whenever you interpret lung ultrasound, you look at that clinical correlation. If you have to repeat scans, you have to repeat scans. In extremely preterm babies, repeating scans has to be balanced against the amount of handling and the risk of actually compromising a baby by excessive handling. It's similar to doing repeated chest x-rays. And that's where I would say that hopefully through the course, we'll be able to give you a good feel of when you might want to repeat ultrasounds in conditions with extremely preterm babies, especially after you've given them surfactant or after you've clinically diagnosed a pneumothorax and or treated it. I think the other aspect that we have to be very, very careful about is that, as I've alluded to, the progress in lung ultrasound kind of findings. So the clinical findings may progress quite rapidly. So you might have a baby who's completely stable where you've done a lung ultrasound, who develops a pneumothorax, and it might actually not be evident on the lung ultrasound, or it might have been there and you haven't seen it. So your previous findings might actually, when you go to that lung ultrasound, retrospectively pick these things up. And again, it's to emphasize this is the nature of medicine and medical intensive care when you're using any diagnostic modality. So for those of you who are practicing neonatologists, the perforation that was missed is something that stands up quite prominently. When you do a chest x-ray for a line, sometimes you see a small amount of air under the diaphragm, which then gets picked up as a significant perforation 12 to 18 hours later when you repeat a chest x-ray because there are abdominal signs and symptoms. And that can happen with the lung ultrasound. And that is not a reason for you not to do it, because this is a criticism that you'll hear from people who don't like using lung ultrasound. Just my last point. Now, we will be teaching you a structured approach to lung ultrasound. I will be talking about this tomorrow. This is very important. That is not just how you do the scan, but what is important about the machine, how you position the baby to optimize your images, how you optimize images on your scan, the structured approach to how you're going to perform that scan in the baby, lung partition, the difference between transitional, transverse, and longitudinal scanning, and importantly, from our perspective, how you then want to report it. Now, we are using, and I will be teaching you one approach. There are 4 other colleagues who are part of this course who have, I would say, more experience than me. At least one of them has actually trained me. And all of us will give you our nuances and our kind of, I would say, experiences of using it. And I would say that the beauty of the course is you have to look through that and then make a judgment of what kind of approach you would like to adopt locally. I think what is important is of our 40 participants, we have participants from the same institute in a lot of cases. And the reason for wanting to have that kind of an approach is the more of you doing it means that you can then adopt strategies which define your protocol and guideline. And I will, at 4 weeks into the course, share with you the standard guideline that we've produced, that we use, that I produce for my hospital in Southampton, which standardizes the definitions, standardizes how we identify pathology, and standardizes how we report. Now, this is crucial because a colleague of mine might be repeating the lung ultrasound in, say, maybe about 12 hours time. It's really important that he knows which probe I've used, what frequency I was used, because a change in probe or frequency, small things like that, can actually change the findings on lung ultrasound and actually make normal abnormal or vice versa. So it's really important that people have that understanding, that they're using lung ultrasound in a standardized way, and that you've agreed definitions of what you think is normal and abnormal based on an evidence-based approach that you can adopt from this course and from the literature. Now, when you plan to implement lung ultrasound in practice, the biggest challenge you'll face is in units where you're doing it alone. And the reason for that is, how do you guarantee that you're using it, that you're practicing it, that you're gaining the necessary competencies? Now, we will give you an approach to how you might want to do that if you're doing it on your own. We will give you an approach to how to do that if you have other people who are learning alongside with you. I think if you have somebody who's already trained and experienced in being able to use it, and that person is happy to act as a mentor, as a supervisor, and can actually help you sign off your logbook, that is really, really helpful. But what is important is that you have an element of didactic knowledge that you have imbibed before you actually set up on your path of doing lung ultrasounds. Now, just in terms of the literature, there's a very nice textbook by Jing Liu that you can buy, which is available on Amazon. But there is a lot of literature that is free, open access, all of which is embedded in your chapters, which provides you exactly the same information. Now, without a doubt, these books aren't cheap. So it's really important that you can use whatever free resources are available. But I am going to say that all the material on our course is kind of a snapshot of the material that's out there. We're probably presenting less than 5% of the material that's out there in terms of theory, practical kind of use of lung ultrasound in neonates. And it is very important that when you complete the course, you continue to read the literature, because lung ultrasound is changing day by day. What we do know is that it has been endorsed for use in practice. So for those of you who would like, I will be presenting the evidence for its use in various conditions with each topic that we present, as will my other colleagues. But I think the debate is not whether there is evidence or not. The debate now is how and when to kind of apply it, and how you would want to kind of use it in your unit. And there are clearly endorsements from the European Society of Pediatric and Neonatal Intensive Care, which gives us guidelines and agreements of how point-of-care ultrasound should be used, but more importantly, how it can be used for diagnosis as well as for synthesis, and I would say treatment-related procedures, surfactant, all of these things. It's now also been recently endorsed by the American Academy of Pediatrics. And clearly, from our perspective, I believe that in years to come, it will become a standard of care, which will be part of every neonatal curriculum in every country. I know that as a fact, it is standard of practice, standard of care. It's been implemented widely in Canadian neonatal units. A lot of units in the States are now adopting it. I know that Dr. Suryavanshi Pradeep, one of my mentors, has trained over 800 people in the use of lung ultrasound in India, and it has been widely practiced in India at this particular point. So clearly, I think it's a great time to be learning a new approach to diagnosis in a neonate. It's something that, from our perspective, we need to know how to use. We need to know how to use it properly. We need to know how to understand the pitfalls of when it can create problems for you. And I think what we'll be providing you is a flavor of it. Clearly, the expectation is that once you complete the course, you continue to take these things forward with you. There are 3 months after the course is complete where you have the ability to continue using the module. And in those sessions, obviously, there might be difficult scans, and as long as you can anonymize them, we will have peer review sessions even after the course is complete. So what is very important from our perspective is that whilst you're using this module theoretically and you're learning from it and you're listening to the lectures, I can't emphasize enough how important it is for you to practice. Now, some of you will not be able to share scans because you can't anonymize them. I can't emphasize enough. I am not in favor of you sharing scans with patient identifiable material. It is a strict no-no. It is not something that I would be happy with at all. I think if you want to share images, what is very important is that you are able to anonymize those images. And I will talk in the next lecture about how we're going to do that. Any questions from that? You guys, if you could just mute yourselves, very important. Yeah. Any questions, guys?
This is Shweta here. Oh, sorry.
Yeah. Shweta, go for it. Yeah, Shweta first. Yeah.
Sorry. Thank you very much. It's a very nice talk. I just have a question. Like in the beginning, you have shown the X-ray where we have to distinguish between the pneumothorax and whether it is there or not. So my question is that, like, what I have learned, like ultrasound is like a 3D imaging rather than a 2D. Like we have done in like a X-ray. So if we have like a child with the pneumothorax, because we have to confirm again and again, like a newborn who has born, and we have to order the X-ray. And while waiting for the X-ray, can we go for an ultrasound? Or can we, after doing the X-ray and confirm the pneumothorax, and we have done like a ICD, like a costal drainage, can we go with the ultrasound meanwhile we are waiting for the chest X-rays? Because in some of the DGHs, there's a problem. We are calling for the X-ray and they are busy somewhere. They have to, like, just how?
Yep. So very much just a few things. So first of all, lung ultrasound does not give you a 3D image. Theoretically, what it is B mode ultrasound, and B mode ultrasound will basically give you what I will describe next week is some of the anatomy of the lung with artifact. And what you're really looking at is you're looking at an area of the lung based on a structured anatomy, which is classified as right anterior upper, right anterior lower. So you're looking at each kind of part of the lung to try and make your diagnosis. In answer to your second question, yes, you can use lung ultrasound as a diagnostic modality for a pneumothorax in the interim while you're getting an X-ray. Now, there's a learning curve to everybody. Now, I've been doing lung ultrasound for 6 years. And what I would say to you is that the diagnosis of a pneumothorax clinically is something that you can make. And a lot of people will argue, well, if you can transluminate and you can make a clinical diagnosis and the baby's desaturating, you're not really going to wait for the chest X-ray to treat that baby. And a similar principle, I would say, applies to the use of lung ultrasound, in that if you've made a clinical diagnosis, I think in a baby who's bradycardic needing kind of resuscitation, you are going to empirically treat that baby based on your clinical diagnosis. But in a baby who's stable, often a lot of us would want a chest X-ray to be able to formally diagnose the pneumothorax before we embark upon treatment. Now, lung ultrasound is something that can be done very quickly, non-invasively, bedside, to make that diagnosis, to help confirm that diagnosis. The question is, would you have the level of confidence to treat that baby based on lung ultrasound as you're learning it now? I can tell you very, very frankly that if you go to Nadia Yousaf's unit in Paris, they don't use X-rays at all. I mean, virtually never. So they feel very confident in being able to do this. I would say that in my setup, at least in Southampton and over here, we'd use it to confirm the diagnosis, but we would be getting a chest X-ray, again, to confirm if the baby was stable. Now, that obviously, with progress in learning, now, I feel confident at this particular stage with my skills to be able to drain a pneumothorax with clinical correlation without doing a chest X-ray. Not everybody would feel comfortable doing that. I would say in your learning curve, what is very, very important is don't hesitate to use lung ultrasound to make your interpretations, to make your diagnosis, and then follow up the chest X-ray to help confirm your learning. And again, that is part of the clinical radiological kind of correlation that I spoke about. So a lung ultrasound in its own, without a history, without looking at the baby, without actually looking at the clinical course, the gases, everything, in itself may not necessarily give you the right information. What is very crucial is that you're using that clinical information, and if time permits, you will do a lung ultrasound, you will get a chest X-ray. With time, as you get more confident being able to assess the different areas of the lung with the different pathologies, you get more confident in being able to diagnose lung conditions where you then feel comfortable being able to manage those conditions without using chest X-ray, which minimizes radiation. exposure to the baby minimizes handling. How long this learning curve is for each individual one of you is something I don't know. But the literature shows that the diagnosis of certain common conditions, like looking at the pleural line, looking at A and B lines, I mean, it takes a few weeks. The diagnosis of a pneumothorax, if the incidence in your institute is very low, if you see one pneumothorax in a year, it's going to take a very long time for you to try and make a diagnosis of and be confident making a diagnosis of a pneumothorax in lung ultrasound with just one baby in a year and keeping those skills. So I would say that what is important is that we first look at the basics, and the basics would say that you treat clinically, you correlate clinically. If time permits at this particular stage, you then, if you feel confident, can do a lung ultrasound. And then your kind of confidence in treating pathology based on lung ultrasound alone depends on your level of skill and how good you are. And that learning curve, that as the chapter on introduction looks at, can vary. But I'm going to take you through the next presentation, and you'll get a flavor of it. Any other questions?
Thank you very much.
I was just sorry. I was just going to ask about the time scale for sharing images in the peer review session. Is it after 4 weeks? Is that what I understood from your?
So what we will be doing is after the first 3 sessions, possibly a 4th session. So we'll be covering protocols tomorrow. We will be covering the basics of physics and generation of A, B lines, what they look like next week. And then I will be covering the normal lung after that. And I think that will be an additional session, which I will let you know about. But the intention is once you've had that, you go through what I would call as pattern recognition. And as the logbook elucidates, recognizing the pleural line, normal from abnormal, recognizing lung sliding, normal from abnormal, recognizing A and B lines, normal from abnormal. And I would say that what we'd like you to do is take 2 to 4 weeks trying to get to grips with that, so that by mid-February, we're kind of in a situation where we've gone through abnormal, and you can then start thinking about, well, clinical correlation, this is what I'm saying. Well, what do I think my diagnosis is? At the end of 8 to 12 weeks, the question then becomes, well, I've actually gone through recognizing normal and differentiating it from abnormal. How would I report it? What are the standards and how should I go about doing that? And typically what I'd say is that at the end of those 12 weeks, that's when your real journey begins. So the peer review will begin on the 26th is my feeling. That's the date where we will start. The intention for peer review is sessions. Look, these are going to be long sessions. I kid you not. And I am going to say you're going to need stamina for these sessions. So we're talking about 45 minutes for peer review, which is usually about 4 to 5 people per peer review session. So on the WhatsApp groups for the peer review sessions, I will be putting up a list which kind of says who wants to present. People first come, first serve, you present, we critique. And really, once we've critiqued, that's something that you can kind of chalk off in your logbook to say, well, I've seen that. The expectation, I would say, in the first 4 weeks is that you do at least 5 lung ultrasound scans to look for pleural sliding, recognition of A and B lines, possibly a little bit more. Keeping it nice and simple, no pressure. And the intention from our perspective is once you've met and feel confident doing that is we'll take things forward from there. But 26th is the rough date when we start peer review.
Thank you.
Any other question? One more question, please, before I move on to the last talk, because I've probably killed you all. Okay, that's a no. I'm just going to give you the last bit of the better tomorrow. Trust me, the cases tomorrow. It's more interactive tomorrow. Okay. So I'm just sharing my screen. So can you see my screen, guys?
Yes.
Yes.
And I'm audible and visible. So just a little bit about your journey,
Yes.
what we expect you to kind of achieve in terms of addressing a standardized curriculum and syllabus. So what we're providing is a standard that's endorsed by the American Academy of Pediatrics and most point of care ultrasound educationalists worldwide. And that is that all courses, whether they're face-to-face, whether they're online, or whether they are sessions where you, say, for example, do a fellowship or work in a center where you're purely doing a particular and learning an ultrasound modality, have a component of theoretical didactical learning, which you complete, followed then by a period of experiential learning. Now, the theoretical didactic learning will be covered in the lectures. So today is a lecture, very little interaction. Some of the experiential learning is something that you will gain by watching. And watching will mean, well, looking at cases, looking at the visuals, looking at the different kind of patterns, and that will be discussed with interactive cases and webinars. And the idea is there's a lot of interaction in those sessions. But then there's an expectation that you have experiential learning by actually doing lung ultrasound in your clinical practice where you work. Now, I think what is very crucial is that you're doing it in a way that is causing no harm to babies, that you're doing it in a way that means that, you know, you have to be careful about practicing on babies. And I think there should be good indications for why you want to do a lung ultrasound. But more importantly, a simple process of teaching for the face-to-face courses that I do is I will consent parents and I will tell them and I will explain the risks for a minute of doing lung ultrasound to 5 minutes and talk to them and then basically do lung ultrasound. And I think what you should be is honest and frank about the fact that you are learning. But more importantly, for those of you who want to share and peer review, get your images peer reviewed, what you will have to do is store them on your machine. And there are governance issues around that, because if you find something wrong, what do you do about that? And I think crucially, that is something that I would expect you to discuss in your hospitals and have gone through a framework. And a good framework from your perspective is you are using it as a modality where technically you're learning. So what is important from your perspective is that the images that are downloaded, if they need reporting, are reported. But more importantly, if it's a skill that you're learning where those images are being downloaded for educational purposes alone, then they need to be anonymized. And they need to be anonymized and stored in a way that they're not patient identifiable. Clearly, if there's something that we identify on peer review, we'll feed that back to you. But this is a structure that is very similar to any course that you learn that's face-to-face. What is very important is that you are working within the frameworks as espoused in the governance kind of frameworks of your hospital. One very important other aspect to it, that what you will be doing is recognizing pathology at some point of your time. And clearly what is important is that when you come to that point, an element of reporting will be needed in your local hospitals. And I would advise that you comply with those standards. What we aim to do, obviously, is cover the didactic principles through the theory. But what you would be expected to do is have a period of training, experiential learning, which you then implement in clinical practice. So once you've kind of done the 3 months of training and the peer review, a good way of kind of coming up with clinical practices to think about how you want to develop guidelines in your own unit. We'll share ours with you. But more importantly, every unit is different. I mean, how you handle the ultrasound machine in every unit might be very different. Infection control practices might be very different. So having a guideline which approaches what we call is clinical credentialing. Now, in the UAE, we call that privileging. And privileging basically means I keep a log for every scan that I do on the unit. I keep a log of the outcome for that particular scan. And if that scan is being peer reviewed, I keep a peer review record. And I would say that I would strongly encourage that you do that. What is also very important from your perspective is that once you're implementing things in clinical practice, images will be stored, they will need reporting, and that you develop a framework for doing that. Gone are the days when we used to use ultrasound. I would say that, and we would report them without actually storing images. I think virtually every institute now has a process of storing images, which means that those images can be reviewed later on, especially retrospectively. And I can't emphasize how important that might be in lung ultrasound, Because if you're doing serial lung ultrasounds, or your colleagues are doing lung ultrasound and they want to look at your scans and they can't see them, then they can't actually see what difference they might have made or why things might have changed. So I cannot emphasize enough how you should have, your guidelines should define a clinical workflow. Eventually, I would say the Canadians have got a concept of institutional credentialing. In the UAE, we have a concept of institutional privileges, which kind of says, well, this is the training that I've received. This is the certification. This is my logbook. This is the guideline under which I'm going to work. So actually, I have got the institutional privilege to carry on with this. A key question from your perspective is, how do you do that if you don't have somebody who can peer review and train you while you're in your institute? So we will talk about that. Most importantly, I would say that what we're aiming to do through this course is basically take you through Kolb's cycle. So you will be reading the material, you will be watching it, you will be then implementing it in practice and learning from it. And then eventually, from your perspective, you will go through this entire cycle again. Now, clearly, how you learn, I would say, is your choice. So for me, I am a thinker and a doer. So I like watching, but basically what I like to do is watch and think about how I'm going to do things and do things. Some of you might actually feel that you can't complete that cycle with actually having done things in practice. So based on your learning modality, the course material provides everything. You can watch videos, you can read material, you practice, and then we peer review. Clearly, what is very important from our perspective is there are limitations to where we can take everybody, because everybody has a different learning curve. In terms of how we address this, so some of you would have already completed formal lung ultrasound training courses, which are face-to-face, but by the end of 12 weeks, you would have done approximately 18 talks, which basically will cover most of the didactic theoretical material that you need to learn. After the first 4 weeks, if you complete 5 introductory scans, which look at pattern recognition, you're able to differentiate normal from abnormal. We would say that you've achieved level 1 of what we call is the British Thoracic Society of Ultrasound Medicine guidelines, which kind of means that you have the ability to be able to recognize, pattern recognize what a lung ultrasound finding looks like. I would say that after that, between weeks 6 to the rest of the year, it's 12 months approximately, I would say, your learning curve to kind of move through a level 2, 3, up to level 4. I think the expectation is that 12 months basically involves you doing a minimum of 50 to 100 scans. Now, this is the ASM, the Australasian Society of Ultrasound Medicine guidance. This is also the guidance produced by the British Thoracic Society of Ultrasound Medicine. And the important thing in this kind of learning curve is that these scans encompass a wide range of clinical pathologies, including normal, including abnormal, and keeping a logbook of the scans, the findings, your reports, the outcomes for the babies is something that is really beneficial if you then want to get formal accreditation anywhere else. Most formal certification courses basically look at a bare minimum of 50 to 100 scans of lung ultrasound accreditation. And this is basically the Australian Society of Ultrasound Medicine guidance. Where we've come up with the number of scans from, your guess is as good as mine. We've plucked it out where, because clearly I will not know your learning curve. Some of you will have ultrasound training already. You do cranial ultrasounds, you do echocardiography. Your learning curve might be much, much, much quicker. For those of you who've never touched an ultrasound probe, that learning curve is going to be much longer. So clearly, what I would say is we should aim to try and achieve, and we will set you up to kind of move on from level 2 onwards. But your ability to complete levels 3 and 4 basically are dependent upon your institutional privileging and doing scans in your setup. I've covered this. The syllabus that we are going to cover in the 20 chapters are the basic principles, standardized terminology definitions, a standardized approach to performing lung ultrasound in the neonate, something that I'm going to address tomorrow, what the normal lung looks like, what the abnormal lungs looks like, in particular, how you define standardized lung profiles. This is an approach that nobody else has used so far. This is something that I have used in my clinical practice and that I will teach you, that I think is really helpful in being able to communicate with your colleagues. Well, if you say there are lots of B lines, well, are there too many? Are there too little? So rather than talking about that, talking about lung profiles in neonates is really helpful. And using Daniel Lichtenstein's classification of the Blue Protocol is a starting point for that. We will then talk about the common pathological conditions that you see in neonates and demonstrate to you how we recognize them. Now, clearly, your ability to diagnose that in your clinical setup will depend upon how common those situations are. I think what I would say is the diagnosis of transient tachypnea is something that you will learn quite quickly. But I can tell you right now, differentiating atelectasis from consolidation is something that still confuses me. And you have to be very, very cautious. You have to scan every lung region. You have to be very careful in situations of trying to make differences in diagnosis there. At the end of the day, what we will teach you, especially in the last 4 weeks, is use of lung ultrasound protocols. So if you have a baby who's deteriorating, well, how would you use the SAFE protocol to kind of approach use of lung ultrasound? Now, we're not in any way going to be able to make you competent at doing those things in 3 months. And I think you need to be realistic about what we can achieve with you. What we will be able to do is set you off on your journey. For me, what I would say is that it's really important that you practice and you practice and you practice. I'm not going to cover the level 2 and 4 competencies at the moment, but this is what you might look like. I'm expecting that by the end of 4 to 6 weeks, you've completed the level 1 kind of pattern recognition. But the practitioner level training really is going to be 12 months of doing 50 scans. If you're completely novice, you've never touched a probe, I think realistically, you're really talking about 2 years of kind of achieving that kind of learning progression. Now, what I would also emphasize is that in your logbooks, we have provided you with kind of a peer review tool. So for those of you who do lung ultrasounds, if you're doing it in groups, a good way of learning is what we call the quorum approach. So the quorum approach is something that I learned in Leicester. It was taught to me by Dr. Akuma. He basically, the approach that was used there was, we're not pediatric cardiologists. Now, neonatologists do echocardiography. Now, saying that you can actually interpret every element of structure can be quite difficult. Now, if you don't have anybody who can actually review your scans there and then, what you can do is you can get a peer to review your scans, people who've trained along with you, who have similar levels of experience in training under what we call as the grandfather clause, where you review your images as a peer group, and then you report or correct any findings that you feel you might need to change. But a good way of being able to kind of peer review that is using an objective assessment tool. And a tool like that basically has been provided by the British Thoracic Society of Ultrasound Medicine, and it's called the ACTS tool. Now, whenever you perform a scan, and this is something that I would do even today, I'm never going to be perfect at being able to do scans, but there are 2 aspects of the scan that are very important. So one of them is image generation, the other is image interpretation. And both of these will be affected by not just my skills, but the baby, how the baby moves, clinical condition of the baby. There might be limitations to how you do the scan because the baby is extremely sick. You might have to limit your views. You might not be able to do a baby in a particular position. If the baby's supine and is so sick, you might not be able to see the posterior regions. And again, we will talk to you about how you do limited scans in that particular setting. But what is important is that after you've completed your scans, you're able to rate both your image generation and image interpretation. And this is an objective tool that you can use to basically assess both. Now, you may well be able to make a diagnostic kind of interpretation of a lung ultrasound, which has very, very poor image quality. And that, for me, I would say is learning there. Because clearly, the question is, while I was able to make the diagnosis, was there something else that I could have done to actually better my image quality? And if it's 3 of you who are learning together and you're able to critique each other, this is no better way to learn. But what is important is that when you recognize pathology, With 3 of you being able to critique and report, that also lends credibility. It lends, I would say, a second check to any reporting that you do, and is a very, very good way to be able to formally report lung ultrasounds. We do that at the Corniche for our echocardiography. And I have done that in Southampton, along with Abhijit, who's part of this course as part of learning lung ultrasound. It is something that I would say, and I would encourage with you. Obviously, if you're on your own, it's difficult. And I would say that if you have a mentor or somebody who can remotely peer review your scans, and they can commit to the time for that, then that is the approach to take. The logbook in this course provides you with examples of how you might want to log your training, continue ongoing scans. I think what it shows, and I will show it to you tomorrow, is how you will progress from pattern recognition to be able to achieve differentiation between normal and abnormal, and then be able to recognize pathology, to then be able to report your scans. And once you've kind of populated it, I would say carry on. So I have my logbook today, and I fill the same logbook for all the scans that I do. I think just there are standardized recommendations on the use of lung ultrasound in different conditions with evidence-based kind of agreement. The article and the link are there for you to read. It's there as part of the didactic learning. I think what I would emphasize to you is this kind of approach that we're going to follow over here, which is, at the moment, we're kind of assuming that all of you have come in at level 1. So you're kind of observing and learning with us. But the idea is maybe in about 4 weeks of doing 5 learned scans, you feel relatively comfortable to be able to progress to kind of differentiating normal from abnormal. And then I would say that the next 2 to 12 months is spent looking at different pathology to build your clinical competence alongside clinical correlation in being able to perform lung ultrasound. I will try my best to support you and give you a good start over these 3 months, as will my colleagues. But please bear with us. I think if your expectation is that you will become experts at the lung and performing lung ultrasound at the end of these 3 months, you're frankly delusional. I would say that after 5 years, I'm still learning. So with that, I'm going to end what was a very long theoretical didactic session on how to use the resources on the website, what your journey will look like, and more importantly, I would say what we are going to do over the next 12 weeks. Any questions? I would love some questions, guys. Anything. Nothing is stupid. Nothing is stupid.
The unit where I work in currently, they don't really have a hockey stick probe, which would be better for an extreme preterm. But because the unit isn't so big on lung ultrasound, and I do it just to keep up with the skills, I use the linear probe. Is that good enough for me to upload the images or to peer review them?
So what I would say is that we asked you a question with regards to probe use, which I've had a look at. And I would say that the absence of a hockey stick probe is not a limitation at all. I love using the linear probe with a higher frequency. I think what I would say to you is, for babies under 1500 grams, using the hockey stick is great. It helps delineate the 12 region approach really nicely. But if you're kind of in a situation where you have a linear probe basically lets you look at the whole lung in extremely preterm babies from top to bottom. It's beautiful. And actually, sometimes I use both. The gist of it is you can use either. You might have to image optimize with the linear probe, especially if you're using frequencies of under 8. So our linear probe it can use frequencies of anywhere from 4 to 18. And I'd say that really the standard is using a frequency of above 8. But more importantly, what I'd say is if you have no probe and you have the cardiac probe, you use whatever probe you have and we will peer review your images. That is really important for me. And the importance of that is, look, there's still a diagnosis to be made and clinical correlation is still important. And actually, if I come back to my mentor, Nadia Yusuf's kind of approach, you can use the cardiac probe, you can use the cranial probe, What is important is that you know the pitfalls of using the probe. And when I use the cardiac probe, I mean, you see what are classically described as B-lines that are beautiful. You just don't see them with the new linear probes and the hockey stick probes. The reason for that is obviously the concept of signal attenuation. A lot of newer ultrasound machines now are basically designed to reduce artifact by filtering signal and noise. And that actually means that what we're doing is we're reducing our ability to be able to visualize A lines, B lines, and artifact that are generated in lung ultrasound. That obviously makes image interpretation more difficult. Some of the old machines actually produce much better images. For me, the advice is please practice with whatever probe you have. We will have a look at the images, but there is a standard way we want you to present that, which I will cover tomorrow. That is in the interest of making sure that you are doing it the right way, that we're getting the best out of you, but more importantly, so that we can optimize and make your presentations efficient. That is because there might be a lot of you who might want to present on a particular day.
Okay, thank you.
Any other questions? I've killed you all, haven't I? Come on, guys. Any other questions? Any questions in the chat? Yeah.
Hi. I didn't understand well how the logbook works.
Yeah. I will cover it tomorrow.
Oh,
but
okay.
Basically, the logbook, okay, let me see if I can share it with you very quickly. Sorry, my computer is a little bit slow at the moment with the amount of material on it. So I'm going to apologize in advance. It'll just take a few seconds. Any questions in the interim while I'm opening the logbook? So the one thing that you will need for the course is what I would call is stamina. These are not short sessions. The advantage is there will be an element of interactivity with the peer review, and the sessions, the teaching sessions will be limited to 45 minutes. So 45 minutes peer review and 45 minutes for a teaching session. And then for those of you who have any questions and have the stamina to go on, by all means, we'd be very happy to ask. But if you have questions, we can answer them on the WhatsApp as well. That's something that we'd be very happy to do. So feel free to ask them. So can you see my screen? Can you see the logbook? Probably not. Sorry. Okay. I'll share again. Is the logbook visible?
Yes.
It is.
Okay. So this is the logbook. This is available to download from the site. Please wait till Monday just because it's been updated a little bit. Now, what it basically covers is who you work with. If you have a supervisor in your training institute, it's worth going through with them. It has a kind of a handshake which says that they're happy supervising you. It looks at basically where you've started from, the number of supervised scans you've done, when you start independent scanning with supervised reporting, and when you start independent scanning with independent reporting. And the idea is that whoever mentors you kind of agrees to that in principle and signs that off. But what it will take you through is some of what I've covered today in terms of the core curriculum, but the ability to, say, for example, put in the lectures that you've attended. Now, these lectures are not limited to training that we're giving you here. You might be attending and keeping CME and CPD of conferences attended, of courses attended, which tick off an element of the core curriculum that we have kept over here, or an element of the British Society of Thoracic Ultrasound Medicine curriculum. So you can log those, you can log them by date. I'll be providing you the Word version of this as well. But what is very important is it covers each parameter that we would expect you to know by the end of these 3 months, which you can tick off and your trainer can sign off at an appropriate time. Now, this is not just how you do the imaging, the quality of the imaging, but it's important that you know your machine inside out as well. I can't emphasize enough how some of the machines, in particular machines with spectral gain and harmonics, can make things better and worse. And I think what I would say is less is more. Keep it simple. Professor Jing Liu is one of the fathers of ultrasound medicine and neonatology, and the machines that they're using are much more advanced than what we have in practice. Clearly, I will teach you image optimization, but I think I wouldn't get you too worried about learning things like harmonics, other things at this particular point. For me, it's really important that you get the basics right. But this is just the competencies on machine learning. Then there are the standard views. Well, what are the anterior lung views? What are the posterior lung views? What and how do you identify bat sign, which is the normal appearance of the lung? How do you identify an A line, B line? Now, clearly, there's a learning curve with this. To start off with, you might, and I would say the majority of people just need 5 scans to identify these 5 things. But once you've done that, I would say you are competent to kind of do these under indirect supervision. And that might mean that you do these under indirect supervision and get them peer reviewed. But hopefully at the end of your 12 to 24-month period, people will be happy that you've achieved these competencies and that you've then made progress in being able to identify these signs to kind of grade abnormality, pathology, which is the next aspect, and then be able to diagnose clinical conditions, which is the next aspect, and then be able to treat those clinical conditions, which is the next aspect. So the logbook basically shows you the ability and gives you the ability to show your progress, which I will say will take years. I'm telling you right now, what we're teaching you is the tip of the iceberg. Lung ultrasound will move forwards. There will be lots of new things that you will be able to see. And I would say that this helps quantify your journey in a very nice, succinct way. It also has, from our perspective, the ability to be able to keep your scans, the images, any significant findings, your reflection. For those of you who know how to do it, you can store your images in the Word document. You can embed them as a video. You can embed them anonymized as images and clips, which is what I've done. And it means that if I've recognized an A-line and found a very interesting image, I've actually stored that in my logbook. That is, that's just the tip of the iceberg with what you can do in your learning. I think pragmatism would say less is always more. Aspire to learn the basics first. Once you're happy you've got the basics, then move on in steps. And I would say that the way ultrasound medicine is taught and the way we're learning lung ultrasound is no different to how we learn cranial ultrasound. We learn it through taught didactic sessions, putting it into practice with peer review from our colleagues. I think the challenge is when you're learning lung ultrasound, you're in a situation where it's the ability to have peer review and to be able to learn in an environment that you feel is safe enough to nurture you. And that is something that we hope we'll address through the first 3 months. Obviously, what I'd say is that, for difficult scans, if you'd like to discuss them in confidence, as long as you're able to anonymize them and they don't have any patient identifiable material, we will try and support you beyond that period. But after 6 months, the next course starts. So I would say that these 6 months is your time to invest in this course and make the best use of it. Any other questions? I'm grateful to all of you. I think you've met the test of great stamina and being able to listen to 3 lectures. I hope I've given you a flavor of what we're going to do. Tomorrow is a very important session on protocols. We start with some case presentations. The session will be 90 minutes, but it'll be very interactive. I would suggest that if you could go through the first and second chapter when you have time over the next few days. But I think what is very important is I'll be sharing with you the standardized protocol that's been published by JLU tomorrow. I think it's very important that you have a read of that and have a good feel of your machines. And if you have any problems with your machines, and we need to look at that, you can actually send me a WhatsApp message, especially if you want to discuss image optimization. The machine that we use currently is a GE. I've used a Philips. I've also used the machine, the Siemens machine, but clearly you all have different machines and we can help you with the image optimization. At the end of the day, using a preset for lung ultrasound is really helpful. And having your techs come in and set up those presets, which are adopted. There's standard presets in every machine, which basically look at different ultrasound modalities, which include vascular. If you don't have a preset for lung ultrasound, it's something that we need to get your techs to come in and look at and set up for you. So I'm going to end there. Thank you very much. Thank you for sharing your evening with me. God bless you.